So deviating from the normal cases, like we'll be going to something a little difficult, which is management of pediatric cataract with microphthalmos. The cases are not that common as compared to simple pediatric cataract. So basically what we need to understand here is cataract surgery and its outcome differ in eyes with microphthalmos as compared to normal size eyes, that's children with cataract. What are the concerns in these microphthalmic eyes? You have very small eye, the manipulation of instruments become difficult. You have a shallow anterior chamber, there is increased risk of endothelial loss. You have a poorly dilating pupil, the surgery itself becomes very difficult. There is increased probability of inflammation, retinal detachment, membrane formation in microphthalmic eyes. The risk of aphakic glaucoma rises considerably. Small eye, a large IOL, there is not enough room for IOL implantation. The cornea is steep, contact lens fitting becomes difficult. It's an infantile surgery. If it's done in an infant, it becomes technically challenging. And of course, these eyes sometimes are associated with systemic associations like rubella. Then patients have microcornea, they have PHPV, which all makes things very complicated. So I'm going to discuss one case. This is a 6-week child who the parents came with a white reflex in the right eye since birth that the child was having. The prenatal history was uneventful, natal history was uneventful, the postnatal history was also fine. The child cried immediately after birth, although the infant IgM IgG was positive for rubella. The child had a PDA for which he had to undergo treatment. The birth weight was almost 2 kg. So this is the child. You can see the right eye as compared to the left eye. The right eye is smaller as compared to the left eye. The cornea is much smaller. The child has a central cataract as well. So when we did his examination, the IOP no doubt was normal. The corneal diameter is much smaller in the right eye as compared to the left eye, which is 7.5 millimeters vertical and 8.5 millimeters horizontal. The left eye is perfect. The keratometry, you can see that there is a difference. The right eye cornea is much steeper as compared to the left eye. And when we did the A scan, the right eye was smaller as compared to the left eye. The axial length was 15.9 millimeters and the left eye was 18.26. The anterior chamber depth was much less in the right eye as compared to the left eye. So all these create problems when you're doing a surgery in these eyes. It becomes complicated. So just to see how it becomes microphthalmosis, this is the normal axial length of as the child grows. So basically, when the child is about 39 to 41 weeks, that's the third row, it's about 16.8 plus minus 0.6. And so the maximum increases axial length is in the first year, after which it gradually decreases to 2 years and then 3 years, and then after that there is a very slight increase in axial length. And this is what we define as microphthalmos. It's basically the axial length is 2 standard deviations below the mean for the age. So if the mean is the central line which is going, the line which is the graph which is down, do we have a pointer? So this becomes your microphthalmos. So this is according to the age. Now it can't be just defined that if the axial length is less than 20 or 21 millimeters, you call it microphthalmos. Those children are above 1 year of age when you have a standard definition. But for infants, it becomes according to the month the child is, the age, according to the age of the child in months. So basically if the child is 10 months and then 20 months and 30 months and at birth, your microphthalmos definition would differ. So in this case, because he had an axial length of about 15.9, a steep cornea, a microphthalmic eye, and a microcornea as well, so we planned for right eye phacoaspiration with primary posterior capsulotomy, then anterior vitrectomy without IOL implantation. So it's very important in such cases not to implant an IOL. It's going very slow. It's very slow. So basically we're just making the side ports at a 15 degrees. You can see how the knife just goes in such a microphthalmic eyes. So plan a capsule exit. The problem is basically after staining the anterior capsule, what happens in these eyes is that although the anterior capsule is elastic, it is friable as well. So one needs to be very careful in doing the anterior capsule exit with a friable capsule because there are chances that it will run out. So again, one has to apply a centripetal force and then complete the rhexis with the capsulorhexis forceps. The manipulation becomes difficult in these small eyes because the posterior corneal surface is very close. And you can see here the nuclear cataracts coming like a central chunk. This is usually the case in children with rubella. And this is when we've done the anterior capsular rhexis. Now we plan for the posterior capsular rhexis. There's a plaque on the posterior capsule. In such cases, in microphthalmic eyes, again the posterior capsule behaves differently as compared to normal eyes, normal pediatric cataracts. It's although more elastic than the anterior capsule, it's again friable. It's very difficult to do it with the start with the cystitome and do it with the capsular rhexis forceps because it really just tends to run out. So basically, you have to use the cutter for completing the rhexis. So these are the problems you have when you do cataract surgery in children with microphthalmos. So this is just a paper we published recently where we did cataract surgery in infants with microphthalmos. All the infants enrolled in the study underwent phacoaspiration with primary posterior capsulotomy, anterior vitrectomy, peripheral iridectomy because we were not implanting an IOL. And no IOL was implanted. So basically these were 37 eyes of 20 infants. The complications what we observed were irregularity of the pupil in 7 eyes, glaucoma in 5 eyes, posterior synecdoche in 2 eyes, and of course visual axis of pacification which is universal to occur in some of the eyes. So basically what we concluded was we did achieve a favorable outcome in infants with microphthalmos without IOL implantation. So this is another study which has been done, but again this is the children are usually older in this study, and what they concluded was that axial length less than 20.5 millimeters was associated with 4 times higher odds of complication than axial length of 20 millimeters was associated with 15 times higher odds. So basically what they concluded was a shorter axial length and abnormal IOP was significant risk factors for complications. So just to conclude, a favorable outcome is possible in most cases. You have to basically modify your surgical planning, adhere to closed chamber techniques. Complications are much more in microphthalmos. Regular post-op examinations to detect glaucoma early because they are more predisposed. IOL implantation only in those with axial length more than 17 millimeters and corneal diameters more than 10 millimeters. Thank you.